Competencies are defined as the development of observable ability of a person that integrates knowledge, skills, and attitudes in their performance or task. AMS competencies are the guiding set of knowledge, skills, and attitudes that result in durable, trainable, and measurable behaviours facilitating better prescribing of antibiotics. Here are some of the key concepts to keep in mind when prescribing antibiotics. Awareness of healthcare facilities' treatment guidelines. Importance and rationale for using recommended empirical antibiotic agents for patients, but also the potential immediate and long-term harm of broad-spectrum therapy. Benefit and safety of de-escalation antibiotic treatment after cultures. Opportunity and benefits of IV to oral switching. Individuals must objectively assess their current level of knowledge and skills related to competency topics and their ability to apply them in practice. These are the levels of competency. Basic. The professional is aware of, has knowledge of, or understands the core principles of an area. Intermediate. The professional is aware of the core principles of an area, understands them, and knows how to apply them in his or her practice. Advanced expert. The professional is aware of the core principles of an area, understands them, knows how to apply them in his or her practice, can show others how to apply them, and provides leadership, expertise or support to others in this area. Local programs need to decide what level of competency is expected depending on their healthcare professionals. Once a realistic assessment of competencies has been established, learning needs and how these needs can be met are then determined. This table describes the competencies for healthcare workers involved in AMS programs in healthcare facilities in LMICs in 5 core domains. The first domain is an introduction to AMR and includes the global situation of AMR and AMS, which involves understanding the morbidity, mortality, and economic threat of AMR to human health. Drivers of AMR that covers the use of antibiotics in humans, animals, plants, and environment, and understanding the development and main drivers of AMR. WASH and IPC, including advocacy for WASH and scaling up vaccines for common infections, and understanding the link between AMS and IPC. And finally, a call for action to promote awareness of AMR and appropriate antimicrobial use amongst all healthcare workers, patients, and the general public to protect the effectiveness of antimicrobials as a public good. The second domain is on antibiotics and includes different antibiotic classes, understanding the clinically relevant spectrum of activity for commonly prescribed antibiotics and using this knowledge when prescribing, and understanding the mechanisms of actions for commonly prescribed antibiotics. PK or PD, formulations and patient characteristics, which covers understanding the basic principles of pharmacokinetics and pharmacodynamics, PK or PD, and using this knowledge when prescribing. Understanding the use of antibiotics in special care groups, for example, pediatrics, pregnancy, breastfeeding, renal diseases, and obese persons. Prescribing principles, prophylaxis, empirical therapy, definitive therapy, and drivers of excess antibiotic use, which includes the following: to understand the principles of empirical, syndromic, or culture-based treatment options in relation to the selection of antibiotics. To understand single prophylactic antibiotic dosing for surgical and other procedures for which prophylaxis has been shown to be effective, and use this knowledge when prescribing. To understand when not to prescribe antibiotics, for example, for viral infections. To understand key elements for initiating antibiotic therapy. For example, the indication for antibiotic therapy, including assessment of the severity of the infection, sepsis syndrome recognition to inform urgency of therapy. And bacterial infection, infection site and probable causative bacteria amongst others. This second domain also includes documentation and communication on antibiotic prescription and use. This involves understanding the need to document important details of the antibiotic treatment plan. For example, agent, dosing, administration route, clinical indication, duration and review dates in the prescription chart, medical records and transfer notes to other healthcare institutions. Ensuring appropriate documentation of antibiotics dispensed, including route, time, dose, therapeutic drug monitoring and response for individual patients. Promoting better patient understanding of all treatment issues, such as safety concerns, including alerts, and adherence. Promoting a standard for the appropriate use of antibiotics, and manage patient expectations and demands, especially when the use of antibiotics is not indicated. It also includes allergies, cross-reactions, and adverse effects. Healthcare workers need to understand the significance of common antimicrobial and drug or food interactions and strategies to avoid interactions. Understand that optimizing antimicrobial use can limit common side effects and collateral damage related to treatment. For example, disruptive effects on host normal flora, which may lead to C. difficile infection, superinfection with Candida species. Understand what to do when common side effects of antimicrobial therapy are suspected. For example, documenting allergic reactions in patient records, reporting side effects. And finally, the EML and the AWARE classification. This competency includes to encourage adherence to antimicrobial formulary or protocol restrictions, to understand the importance of promoting appropriate use of antimicrobials according to their AWARE groups. The third domain is microbiology and includes important terms that need to be understood, such as the differences between colonization, for example, isolation of bacteria from a skin wound or urine with no sign of inflammation or infection, and infection. The difference in microorganisms and resistance patterns for infections acquired in the community compared with hospital settings. Common causative agents and resistance mechanisms such as understanding the common and important gram-positive and gram-negative bacteria, WHO priority pathogens list plus C. difficile. Understanding local AMR epidemiology, resistance and susceptibility patterns amongst others. Data collection and analysis is also important. Healthcare workers need to be able to collect microbiology samples correctly, be able to interpret and use basic antimicrobial susceptibility testing results and other microbiology testing tools. The third domain also includes selective sensitivity reporting or antibiogram. Healthcare workers should advocate for and comply with guidelines regarding antimicrobial susceptibility testing. Understand how to implement selective sensitive reporting to minimize broad-spectrum antimicrobial use. And finally, bug-drug combination chart. Healthcare workers should understand the common microbiological etiology and treatment of human infections. The fourth domain focuses on clinical syndromes and includes guidance and best practices in antibiotic prescribing. This involves understanding how and where to access relevant guidance on antimicrobial prescribing and AMS, and use this knowledge when prescribing. Understanding that empirical treatment should be guided by local antimicrobial susceptibility patterns. It also covers common infections, in which healthcare workers need to understand the decision process for appropriate antibiotic use. Clinical assessment and clinical symptoms, probable diagnosis, causative agents, diagnostics, patient characteristics, whether or not to treat with antibiotics, and how to choose antibiotics to treat or prevent common infections, including CAP, UTI, diarrhea, SSTI, sepsis, bacterial infections that resolve by themselves, for example, sinusitis and otitis media. The fifth domain focuses on AMS and includes planning an AMS program, which involves providing clear governance mechanism for the AMS program, understanding the use of a quality improvement model to address gaps and to improve antimicrobial use in the facility, performing AMS interventions by understanding the key elements of a logical approach to continuation and appropriateness of antimicrobial therapy and be able to implement AMS interventions, for example, switching antibiotics from intravenous to oral administration as soon as possible when indicated, changing antibiotics, ideally to a narrower spectrum, de-escalation or broader escalation spectrum, accordingly to microbiology results and clinical condition, assessing an AMS program, which requires understanding the types of indicators, structure, process and outcome measures, identifying sources of data, recognizing the benefits and limitations of each. Once the facility has outlined the competencies required for the different healthcare professions, a training delivery plan needs to be developed. Clinical opportunities for training, such as ward rounds and clinical case discussions, should be emphasised. In addition, trainees should be encouraged to access external training opportunities, including available e-learning options. Integrated learning translated into integrated practice. There are different education and training delivery modes for AMS-related competencies, including professional organisations, university, educational workshops, continuing medical education, network, e-learning and on-the-job training, among others. Let's start with pre- and in-service training. AMS linked with IPC should be incorporated or strengthened in pre- and in-service training, curricula and textbooks. Voluntary or mandatory in-service training on AMS and IPC is encouraged, for example, through continuing medical education. Organise face-to-face workshops structured around the list of AMS competencies, based on the local needs, context and resources. Blended learning combines face-to-face learning with online learning and is becoming increasingly popular as students can partly control the time, pace and place of their learning. AMS teams and AMS champions are encouraged to gain practical hands-on training through WHO collaborating centres and centres of excellence. Countries can also set up twinning or mentoring programs for AMS. Successful training makes use of both existing structures and opportunities that arise in the clinical environment. Holding ward rounds jointly with the unit health personnel and the AMS team is among the most dynamic instances of learning. Every member of the team attending to the patient has the opportunity to give their opinion, debate the pros and cons of each diagnostic or therapeutic decision, and understand what is best for the patients. E-learning is one important form of effectively delivering education in AMS. Using e-learning can result in greater educational opportunities, simultaneously enhancing faculty effectiveness and efficiency. However, this potential of e-learning assumes a certain level of institutional readiness in human and infrastructural resources that is not always available in LMICs. Here are other examples of facility structures and meetings where training could be provided. Morbidity and mortality meetings, audit meetings, quality improvement and safety briefs, significant event analysis, risk management meetings, journal clubs. The challenge for AMS facility training is to ensure that the capacity and capability exist for delivering a quality, effective and sustainable program or course. Therefore, having a simple model to ensure implementation of this program is important. Here are the core steps for implementing an educational program. 1. Program leaders, often the AMS team, are identified and should have acquired the advanced competencies to lead and deliver local or regional training. 2. Training of program leaders may require 2 to 3 days of face-to-face workshops using local, regional, national or external resources. 3. Access to e-learning resources to support this is recommended. These leaders will require skill sets that have been identified in Train the Trainer models. 4. The program leaders in each facility or region identify a multidisciplinary faculty of trainers for advanced training in AMS. Again, access to e-learning resources to support this effort is recommended. The faculty will develop the local program. It is always helpful to include at least one prescribing non-specialist as part of this group. 5. The faculty identifies learning needs and creates a learning program. They devise a program cycle that includes the target audience, course content, and evaluation. There are many factors to consider when developing an education and training plan for AMS. While face-to-face training methods are the norm in many LMICs, more active methods such as e-learning, blended learning are increasingly used. Use of online and mobile digital education in management of antibiotics for post-registration healthcare professionals is associated with increased professional knowledge compared with traditional education. E-learning approaches have been shown to provide flexible, low-cost, user-centered and easily updated learning. The effectiveness of e-learning varies from context to context and has been shown to make considerable demands on users' motivation, levels of digital literacy, and on the capacity of providing institutions. These considerations must be taken into account when developing e-learning courses. Teaching methods for AMS interventions include active and passive methods. Generally, active methods are more effective than passive methods in changing prescribing behaviour. Passive methods include printed educational materials, clinical practice guidelines, formal lectures, seminars, conferences, educational courses, reminders, distance learning, e-learning. Active methods, on the other hand, include discussion groups, journal clubs, educational outreach visits and academic discussions, audit and feedback, interactive role-play, case scenarios, interactive educational workshops, sequenced educational sessions, learn, work, learn, learning by working, practice, distance learning, e-learning. You have reached the end of Module 6. Try to answer these questions to check your understanding so far.